All right, I just let everyone in, so everyone's should be coming on now. All right. Okay, so Georges, do you want to get started immediately?
Sure, yes, we can get going.
Okay, all right. Amir, can you start the live stream countdown?
Sure, here we go in 5, 4, 3, 2, and 1.
Hello, everyone. I'm Dr. Georges Benjamin. I'm the chair of the Committee for the Analysis to Enhance the Effectiveness of the Federal Quarantine Station Network based on lessons from the COVID-19 pandemic. I have a public disclaimer that I need to read because this is a public meeting. And so this is the note that this is an open, on the record information gathering session. That means that the committee is in the process of assembling materials that it will examine and discuss in the course of making the findings, conclusions, and recommendations. Therefore, I ask everyone here today to be mindful of the fact that the committee has made no conclusions and that it would be a mistake for anyone to leave here today thinking otherwise. Comments made by individuals, including members of the committee, should not be interpreted as positions of the committee or of the academies. Now, this is the second meeting of approximately 4 to 5 planned full committee meetings. And some of these meetings may include public sessions where we will have the opportunity to hear from experts in the field. The committee will deliberate thoroughly before writing its draft report. Moreover, once the draft report is written, it must go through a rigorous review by experts who are anonymous to the committee, and the committee must then respond to this review with appropriate revisions that adequately satisfy the Academy's report review committee and the chair of the National Research Council before it is considered an NRC report. The expected report release is May of 2022, and further information on the study, including future meetings, can be found on the project website. Now, today's open session provides an opportunity for the sponsor of this study to address the committee and describe their perspective of priority issues within the Division of Global Migration and Quarantine so that we can better understand the scope and purposes of this study. Now, during the Q&A sessions and discussion, the committee questions and the comments will take priority. The public can submit comments to the study email address listed on the project website. This meeting is being recorded. It is now my pleasure to introduce Dr. Marty Citron, Ms. Jennifer Bugot, and Mr. Brian Mascari, who will discuss their perspective on the statement of task. With that, I'll turn it over to Jennifer, Brian, and Martin. And Marty, I think you're muted. Still muted.
Okay, sorry about that.
There you go.
Unmute and share screen at the same time. My apologies. So I think that one of the things that has been asked of us in the interim between the sessions was to review the sort of scope and mandate and see exactly how to prioritize some of the tasks of the group in light of the issues around the sort of quarantine stations in the field and the broader issues. I think in the opening sessions, you've heard from a number of the different branch chiefs in the regulatory program across Dgmq. I did want to, move through the kinds of questions that we had hoped that you guys would be able to focus on. And I'm assuming you can now see the slides as they are advancing, but is that just, please say that's correct. It should say review slide 2. Is that up on your screen?
We have, review differential international approaches. But if you could put that in what is it?
Yeah, slideshow.
Slideshow function, yeah.
Doing that right now.
Us old guys with small eyes can.
I know, I don't it doesn't seem to be advancing that way. Let me just try again. Make sure I'm sharing the right screen here. And if not, I believe Brian sent the deck to you folks before the call. So if I can't get them to blow up into full view here, we'll.
Marty, try slideshow.
Yeah, I did. On the bottom and on the top. So let's see if we can get that. My screen is showing that it's full view, but I can see that it may not be. In any event, let's just as a backup, whoever's got the slides on your end at NASEM, if you want to show those, and I can just say advance because I'm not sure they are. And I can also try to just expand this window so it's a little more visible and shrink the slide.
Yeah, that works better. If you can you advance your slides though?
Let me just confirm that. Are you able to see the third one now? Did that advance?
Yes.
Yeah.
Okay. All right, good. Let me try to catch up and just go through this. So back to slide 2 here. So the one of the issues that we really had prioritized, and it's come to a special fore this past week interval around Omicron, both in the air and in the sea environment, some of you may have seen in the news. We would like to review the different international approaches to identifying effective interventions and best practices to mitigate the risk of disease importation. And I'm specifically talking about the surveillance eyes that are needed, not only on a national surveillance program and a national sequencing and strain awareness program, but also with an eye toward importation. Because as we've seen, most of the national systems, when they exist at all, are really snapshots of the present in some sampling scheme of the proportion of different variants. And we know right now we are in a Delta surge in the US and still in many other places. And with that surge, it masks actually what the importations might be looking like. And so over the weekend, we've accelerated some of the pilots at focused airports where South African and other Southern African arrivals and European connecting flights are coming, to be able to see the magnitude and the impact of early introduction of new strains. We've had the same system going on in the sea environment and have found an early introduction onto a fully vaccinated and fully tested in advanced embarkation-based tested group that happened below the radar in a South American crew member on one of the ships. And this is the kind of augmented surveillance we need to have. However, it is quite challenging when the volumes are large to triage the follow-up in a way that's efficient. So looking at the ability to use digital technologies and real-time data systems to provide light touch, resource focused engagements so that the public health community can still have eyes and ears on what's going on, but perhaps prioritize human resource engagement in these early introductions in a very focused way that is not overwhelming when we're facing a sort of a nationwide pandemic and still in the Delta wave or the prior wave. So I think recognizing that viruses emerge during pandemics and other things, and realizing that we have to operate in multiple theaters at once, and we need to have early eyes on problems in addition to contemporary eyes on problems. How do we use our assets of this division in the introduction phase to do both of those things without overwhelming the system? I think the examples on this slide are just some of a few about that. Contact investigations that can be done effectively with digital engagement, and then prioritize follow-up where there are known cases. The use of digital health certificates more completely and more effectively. I think we've seen that in a number of other countries. Real-time data systems that have aggregated data across backends, but in a very timely way, and can provide update to situational awareness systems, on the front end that are widely available by all the responding community. I mentioned light touch risk assessments, how do we do post-arrival monitoring of a large cohort to find what may be an early problem or a problem of a few, and how do we balance the digital toolkit in its means for mitigation and protection against, the very crude use of border restrictions. When we can't do the former, we end up getting stuck in the space of the latter. And there's a lot of, as we know, both, lack of efficiencies in that approach, lack of targeting in that approach, but also a lot of potential collateral damage. So timely, as we talk about moving from the Delta wave into what's potentially an Omicron wave, but also a problem that we've been facing throughout many infectious disease responses. So that is really a priority issue for us, for the committee to be able to weigh in on. Secondly, how do we apply these innovative approaches in the US context when we have multiple ways into the country? I think we have over 400 international airport arrival places. We have the land boundaries on the northern and southern border, and we have increasingly large volumes of seafaring traffic that is both essential goods and services through cargo, but also large commercial cruise ships and others that really deal with big volumes of people that are not just domestic passengers, but they're international environs. They're microcosms of the globe in many ways in terms of crew and passengers. And they have a continuity population that is the crew, and they have an ever-infusing population that is the passengers, often turning over at 7-day increments. And so these are risk environments that are worthy of special eyes and ears and good approaches to mitigation. The other thing I think we've seen throughout this pandemic, and it remains an issue, is the need for some type of larger scale dedicated federal quarantine and isolation ability. That is literally infrastructure for managing infectious cases on importation in places where people may not be at home and may not be able to self-isolate or self-quarantine, or for individuals who would refuse a voluntary, lesser restrictive means. We just don't have that kind of facilities at scale at this point. And we've been stuck in these situations of finding space on military bases, as folks know at the beginning of the pandemic. This also applies in non-pandemic settings where there's large migration emergencies that may be coming either mixed with or areas of vulnerability for residual infectious disease threats. And I sort of highlight the large-scale, very essential and very important evacuation of our Afghan guests out of Afghanistan in an urgent way in order to provide safety and safe haven, but also doing that in the setting of providing the proper screening and infectious disease intervention. So this capacity issue is something that needs to be addressed, and it's not limited to a pandemic specific kind of situation. And so I think that's another really important issue for us to get the committee's thoughts on. And then finally, or if not quite finally, but to review the needed changes in Dgmq's infrastructure, because we are continuing to face this push-pull response staffing that surges late when money is available and then sort of yo-yos up and down, but persistent engagement or multi-theater engagement as we've had for the last 2 years in the setting where pandemics and other kinds of threats can become disruptive for longer periods of time rather than weeks to months, maybe months to years, and how that intersects with the syndemics of the effects on, migration emergencies. And I think I've laid that out in an earlier session. So what's the best approach for Dgmq to have the proper organizational infrastructure as well as relationships in place? And that applies both within the agency, within the US government, in the interagency space, with state and local health departments, but also in the international arena. And the last bullet on this slide is just a comment about what has been required over the last 2 years in a reconstitution of a permanent maritime unit that's capable of not just the prospective approaches to improve prevention, but also the
Il
detection.
problema ha lasciato male quel coso.
Allora, ti posso dire una cosa perché io non volevo dirlo davanti.
I think there's a hot mic somewhere. So I think that is, I want to just make sure I'm not missing one. Oh, the last one we talked about that is a real priority is what is the approach to the novel use of regulation that we've experienced during the COVID-19 response. And here we've had a number of different challenges. One challenge on the theme of is the full level of authorities that the agency and the department has available to cover the kinds of circumstances. How do we deal with the gaps in regulatory authorities, and how do we integrate the scale up and implementation of new orders under those authorities? And finally, what do we do in these fringe bases where there's been challenge to whether the existing quarantine authorities actually cover the margins of infectious disease driven consequences, for example, the eviction order, et cetera, and the necessary need because of the impact of evictions and homelessness on accelerating the pandemic, but without the specific words used in some of the authorities, do there need to be statutory changes in this frame? And as well, recognizing that there's a delicate balance between the federal jurisdiction of regulation around importation and spread, which is arrival, interstate commerce, failure of local control, request for assistance at the local level, and federal properties within states being the basic scoping frame, and that the majority of isolation and quarantine public health authorities are really ones that occur in states and at the state and local level, and just figuring out what is the right relationship and what areas of strengthening are needed and what areas of clarification, whether they be in regulation or statute or in implementation. So those five, I think, really lay out what we see as the most important priorities for the group. I will remind folks of our structure in this last slide, and I have a few slides that speak to the issue of migration emergencies and vulnerable populations that are that have been presented by Nina and others earlier in the meeting. But this is the current basic sort of branch organogram structure in the spaces in which we work. We have many more offices and entities, but all of these things actually are very, very tightly integrated. And as I said before, the syndemic of pandemics as it affects the border health or the conveyance movement itself really belies the fact that the division is responsible in this mission across the entire journey from origin to destination, and all of those issues of detection and strengthening surveillance of abilities to prevent and intervene with known services, the ability to detect and stop an outbreak from getting to us in the first place, are all really key to this overall mission. And I realize that you're looking for some prioritization and scoping, so I hope the first five did that in that regard. And there's a couple of extra slides here that we can get to if the conversation veers that way. So with that, I'll turn it back to you, Georges.
Okay, thank you. Let me, just a couple things. One of the things you asked about, and if anyone has any other questions, please raise your hands. But I had a couple. The ability to deputize, train others within your scope, whether they be CDC staff or local health department staff, to kind of serve as a surge workforce for you. Is that possible?
So the short answer is yes. There is a delegation, a chain of delegation and authorities, and that chain of delegation has to follow a proper sequence of sort of hierarchy in that regard. And so during this response, we have actually delegated some of these authorities within that chain to expand the pool of people, including appropriate folks outside of the division, but inside the agency. I will say that these kinds of decisions and authorities are inherently governmental work. And so these are not the kind of things that are delegated to a contracting workforce or a surge workforce in that framing. But within certain limitations, the ability to deputize and delegate has worked. I'd say one of the areas that's been gray zones with speed is how quickly we can get state and local health department folks into secure, sterile areas at the airport in order to augment some of that work. And that has been a challenge in terms of speed, not necessarily one that is insurmountable, but we have to have in our surge contracting plans, we've had to predefine the early phase of a surge workforce, either as CDC folks who can meet those badging requirements and bonding requirements, or a pre-existing contracted force that's already gone through that process, providing they haven't turned over staff. So there are limitations to what you're saying, but there are some ways, and we've already, I believe, tried to maximize the ways we know about how to do this. And I think we're looking for additional ideas. We've also brought in DHS personnel in order to augment that needed workforce in the secure, particularly secure areas. And we rely very heavily on that MOU as well.
I'm gonna do Michelle, Larry, and then Jason.
Hi, Marty. Good morning or good afternoon. My question's about the balance of power between the federal and local quarantine enforcement. And I think we had a discussion before you came on and we were all confused, particularly around who is empowered to actually do mandates for testing, the timing of testing and quarantine. Are you empowered, or is it the presidential office? Could you just clarify that for us?
Well, you're right to be confused. It's a very complex space, and it has involved lots of conversations, not only within the Office of General Counsel at CDC, but in the interagency as well. And so, to be honest, the scope of federal authorities are fairly defined. The enforcement of federal authorities can be facilitated by state and local. So federal orders can be facilitated by support from federal and local, for example, law enforcement, and vice versa. They can be requested, state and locals can request assistance from feds on those orders. But when we talk about the pre-departure testing requirement, for example, as a condition, a negative test as a condition of arrival, and the CDC clear recommendation for a post-arrival test properly timed in the incubation period at 3 to 5 days. Once a lot of those folks are moving out of the federal space, figuring out that type of relationship and that handoff and what's facilitated and what needs to be handed off and taken over is a complicated gray zone. I'll leave it at that. We can sort of discuss that more in a dedicated session around this, I think.
That can be a task, our task as well.
Yeah, I think it's important to get really deep into this. I know that you've had some requests about getting some other folks involved who are studied in this matter, and I would look forward to having those policy and legal conversations together with you at a future date.
Terry Gostin.
Yeah, first picking up from what Michelle and Marty were just saying, and then just pivoting to a slightly different thing that really raises some of the issues George has mentioned. I can help untease some of those things, but if Abby Gluck is going to be doing the paper for us, Julie, one of the things that we should ask her to do beyond federal authorities, and then is the handoff to states and localities. I think that would be really extraordinarily helpful. We need to untie a lot of this. So part of it has to do with, when a federal testing requirement is imposed, does CDC have the power to do that, or does that require presidential action. I mean, that's one set of issues. Another set of issues is, do we want to change or expand that in any way? And I think that's quite important. These are all things for us to think about with Abby. And then next, how do we, and it's really delicate. It happened during Ebola, Marty will know, in terms of, quarantining people when they came back, formally, while the person is at the airport and before they've cleared customs and left the secure zone, they're under federal authority. Then they're under state authority. And then how does that transition and harmony take place? I think it's really critically important, and it goes to a lot of Michelle's earlier concerns about federalism and how we deal with that. So my question, Marty, I think you're so right about the idea of, when you have to have testing, but more importantly, quarantine authority and the facilities. It's always been complicated. It was during COVID and the cruise ships. It's very awkward to go to military bases and things like that. And so it seems to me that you're thinking about expanding federal quarantine capacities is absolutely right. My question is that, number one, what would that take? And secondly, operationally, since this is episodic, it will come in, there'll be long periods of where you're never going to be using these facilities. And then there'll be a surge. How do we think about that?
Yeah, so what's episodic in the past, say 100 years in terms of large scale events, I would say the kinds of needs in which this has emerged, at least over my 30-year career, is definitely speeding up. On the other hand, I would say that on the individual basis, even very simply on the individual basis for folks whose either legal status or residential status falls into these gray zones or is ambiguous, that probably is less episodic and potentially another area. I think there's a lot of ways. We've talked within ourselves about a number of ways to do this. It's not that there's necessarily a lack of the ability to conceive of the need that has some inhale, exhale flex. It's a little bit about what happens in the downtime. And I would think that in the downtime, a preparedness function, sort of a warm readiness function, existing agreements and contracts for surge, but the ability to utilize the facilities in peacetime, if you will, for preparedness and readiness and exercising and various scenarios, whether they're small migration, emergencies, lifts. So you may not have all of the staffing you would need for a large serve on board all the time, but you may actually breathe in and out between preparedness and response and have a readiness set of body contracts to build out resources. But you would need to actually have some of that physical space be either separately set aside or easily expanded. And we've seen a lot of that need go on, whether it's the southern border or the Afghan evacuation, other things. There's a combination of a way to, for that inhale, exhale to occur, soft-sided facilities, depending on weather and climate and condition and appropriateness, et cetera. But I don't think that building them all, running through all of that constantly in the middle of a crisis is actually in any of our interests, and really recognizing that this is a need and then figuring out the best way to adjust the roles and responsibilities and the size of the footprint is better than trying to build these things constantly when it's in the rearview mirror, and it's really hard.
Jason, Stephen, and Marcy.
Thank you. My question is about digital contact tracing. So the low energy Bluetooth has been used very successfully in the UK and Wales, and with more than 50% adoption, and 75% of people agreed to send information if they tested positive, and so it's been a very successful program. when we look into the implementation in the United States, what we found is that, for example, if it's a state authority and, with the Bluetooth handshake, if someone had a handshake in California and is traveling to Boston and then transfers to Chicago, then there's 3 different states that we're talking about. And the server for syncing the Bluetooth handshakes becomes problematic. Even though, Bluetooth, is randomized digital codes that if the handshake is less than more than 10 minutes or within a 6 feet distance, that it would send it to the server. But then the server needs to be synchronized if we're talking about, coordination across the different states for the purpose of contact tracing, particularly when people started to travel again. And I wanted to sort of get your thoughts on whether it's feasible for CDC to keep such a server. What do they need to be rely on, at the state level when we do digital contact tracing? And by the way, digital contact tracing reaches different people than manual contact tracing. They tend to reach people outside of the household, particularly people in the metro that you don't know and you happen to be sitting next to. And so it's a very different function than manual contact tracing. They should be used together.
Yeah, and I would say, I wanted to tease out 2 things. You're bringing up excellent points, Jason. And I think I want to tease out the proximity-based apps that often where Bluetooth is really good at being able to give you proximity signals in terms of exposure contacts and so on, from the digital solutions that may not be dependent on Bluetooth, but may be linked server-based or position-based or GPS-based. And often they're connecting through internet servers or internet platforms, cloud-based solutions. And what we've seen is challenges in both of those, but both could probably be advanced, and they would need to be then advanced and integrated. For example, where we've seen problems in doing this in the Ebola setting is we had a lot of international movement. And even when people are proximate, but they cross a country boundary, the serving, the cellular network has then suddenly switched over, and everyone's experienced this when they travel internationally, says you're now bumped into this other cellular service and so on. And so that represents an integration boundary when you cross a jurisdictional lane, and then the access to even within one country, sometimes you're crossing satellite server distributions or crossing platforms that people use. So there does need to be a cloud-based server integration function that's able to share securely information, because the bugs don't know the boundaries and the rest of us are constrained by a various set of technical solutions. I think those are solvable problems. With respect to Bluetooth issues, then you have the sort of known and unknown, and it's the large exposures in congregate settings like we're seeing now with the anime conference, for example, in New York, and contact tracing around the convention centers. Hugely challenging. It's got both an international and a domestic domain, and a familiar and a non-familiar domain. And it's super hard, but it's important to be able to do these kind of things much more swiftly than the approaches public health, the analog approaches public health is relying on now. And it's very resource intensive. And as everyone knows, that if you don't do it fast enough, you're many generations of transmission behind. It's impossible to play catch up with a fast virus and a slow, human-based analog solution. So I think both of those pieces need to be, sort of thought through technically and beefed up with significant investment.
Stephen.
Yeah, thanks, Marty. I thought that was a very helpful presentation. This is a little bit of a follow-up in what Larry had mentioned, which is this idea about needing facilities to be able to house people, and the fact that it's happening much more frequently. I mean, I guess one of my questions is, being that often you turn to the military, or somebody turned to the military to be able to house these locations, how receptive was the military to actually playing this role? And the other aspect of it was, if I remember, especially early on, there were a number of jurisdictions around the country that almost automatically said they're not coming here. I remember there were communities in California, the state of Alabama, I think, said you're not putting them on military bases in Alabama. And so how do you deal with that? And would you put agreements in place ahead of time so that you don't run into those types of situations again? And are there other models that you've been thinking about? And I know you've mentioned looking at what other countries around the world have done. A lot of them, used hotels to be able to accomplish this. So I'm just wondering what your thinking is there.
Well, you're spot on the problem. So I have to say that our DoD colleagues, once it's decided it's going down, have been incredibly, gracious partners. It's not the intent or design or easily aligned with mission, and sometimes it requires, compromising, whether it's space or a planned event or lots of things that get in the way because it's not sort of a pre-planned thing, as you've said. So we're often always asking again in middle of a crisis when there are competing priorities, and it's not easy to do. And whether it's the Southwest border issues or Afghanistan resettlement or other types of things, the opening of the pandemic and repatriation, these are often whole of government needs, and it often involves brokering, decisions and solutions that involve whole of government directives and clarity. But it's challenging. I think we could do better if we prepare more in advance. There are a lot of other solutions. We've seen successful use of hotel solutions. Sometimes those have involved pre-purchasing either entire facilities or large blocks. We've done that. We've seen state and local folks that are preparing on their own right doing that. Marcy can obviously chime in as well as others on what happens at the state level, preparing for contingencies of international arrivals when people aren't home and they're guests of your state or your jurisdiction. I think there are also, we had a small scale solution at the end of Ebola, West Africa, that involved the Nebraska facilities. And we saw even exposures that happened in response mode for CDC staff or potential exposures where we need to relocate just small numbers, plain fulls or family members, both for medical care in the acute setting of a known case, but also for a small quarantine cohort. And we've been able to take advantage of that small size capacity at the University of Nebraska, where there's both specialized care, Emory as well, for example, but also a set of shadow beds for this kind of small number solution of people who need to be observed, but don't need to be taking up, critical beds in a hospital, but need to be able to move quickly if they progress over an incubation period. So we've been through a number of sort of solutions created in the moment. I think it's really would be very beneficial to have a more intentional and deliberate planning process that involved MOUs and involved knowing if we're doing the 1s to 10s, 1 to 20, what type of solutions are available in that setting, what's their geoscope in terms of location around the United States, proximity to an international arrival point, likelihood by state of area, and then the larger scale things probably need a different solution. Large congregate settings on military bases are not necessarily the best solution for bringing thousands of folks who are at risk together, because it's very hard to parse the infection risk and the transmission risk in those spaces as well. So these bases weren't designed to be isolation and quarantine facilities. They were designed for a different purpose, troop housing, congregate eating, that kind of thing. And some of those systems need to be adapted if they're going to be more regularly used in this type of response.
And the other part of that was the jurisdictions that were unwilling to.
Yeah, and look, you're spot on as usual on many things on that as well. I mean, there's not only finding the place, there's getting buy-in at the community level with the NIMBY problem, which we face all the time. And every time when we're trying to do a safe evacuation, even to the point of a flyover or a governor in a particular area, if there needs to be a spot for refueling, or the hospitals have agreed, but on the other side, and I'm just speaking about the broad set of experiences, it doesn't really matter what the politics du jour are. The issue is infectious disease threats create fear for the unexposed population, and it's a challenge to be able to integrate all of that preparedness thinking in a way that everybody who has equities are comfortable, regardless of what the political climate is. I think that's a real issue to be, and again, where advanced planning doesn't leave us stuck at the last moment of a 3/4 negotiated solution that ultimately ends up, blowing up over sort of miscommunication or misunderstanding.
Let me ask this, Marcy, do you still have a question?
First off, I apologize. I'm having internet problems, so I called in and I don't know what I missed, so it may have been addressed. But Marty, I was going to ask two things. I think one, you've already talked about the surge capacity. I know in New York City when I was there, since I left last Tuesday, but we have a agency-wide incident command system that pre-assigned roles, so people would know what their roles were ahead of time. They were trained on them, ideally, at least once a year. And I didn't know if that was something that CDC formally did to be able to pull staff in. So, but I think you addressed surge capacity, so no need to go back. But the other question is a more general question, because I realize it's something I've asked the state and local panel tomorrow to think about, but this issue of when sort of like for what the characteristics of what type of new disease or organism, does it make sense to do what we're doing with COVID versus more just, potentially just education? This is related to the active monitoring, because there's no question there's a great burden once people pass through. You've already acknowledged, in New York City, we have a lot of people who were just passing through and sort of were pulled off, and then we had to figure out how to deal with them if they were positive, which is always challenging. But, I had never thought that we would do what we did for an organism like COVID. It was never sort of in our pandemic influenza plans. And if there's been thoughts about when this makes sense, like I realize in the beginning you may not know, but if there's been thought and sort of clarifying the criteria that you would want to put this in place for in the future.
Yeah, excellent questions, Marcy. I'll take the easier one first, is that CDC's response planning does involve a set of clearly defined roles, a regular period of exercising, and a very frequent sort of set of training opportunities before, during, and after various responses for different role levels, so that there's various other things for the international response role, in which a group is predefined and then stages up and has on-call periods, much like it does in the Commission Corps and other places at HHS. So that one is a little more straightforward. I think the second question requires a lot more thought. I do think that there are these phases. There's the opening acts of a new threat where you really don't know what you're dealing with. Then there's that long middle, which is the hardest phase, in which there's really no countermeasures and insufficient diagnostics and insufficient surveillance, sometimes to have eyes and ears on the magnitude of the problem or the scope of severity, the range of severity. And then there's the sort of, we get additional tools in the toolkit, be they treatments or vaccines, and we have kind of the rollout phase. All of those have intersections. And I don't think that there's been like, we're going to go down these known pathogens or known set of criteria on transmissibility, morbidity, and mortality, and look at that nexus outside of the formal sort of pandemic flu scenario, in which we have that laid out, right? There's that scale, that projected impact, highly transmissible and highly lethal, putting you in quadrant 4, and there's a whole sort of range around planning. And then the other part that needs to be intersected with is where you are on the spectrum of the epi curve, and how many waves might you expect, and will your assumptions at the beginning of wave 1 hold with wave 4, or with pathogens that mutate. So I think that more can be done in that space. Most has been done around the flu scenario, but I think we actually can see that there are more threats than just the influenza playbook that need to come into play. Some of these things will be consistent with that matrix of transmissibility and severity and population susceptibility. That's a reasonably good guiding principle, but there's a lot that emerges that we don't know about those things, and two, those things will change over the course of time as the virus itself evolves and mutates, and our countermeasures come into play that sometimes may work and then later may not work. So it's a really big problem. It would be worth a dedicated look at that to space those out. There's no doubt about the burden being high on human resources. And I think that's why we think that a lot of the filtering and focusing can be done through low touch, high impact, fast speed, augmenting digital tools that should spare the burden.
Let me, I know we're getting to 1:30. I don't know if Brian and Jennifer had anything that they wanted to add.
Well, this is Brian, and I think Marty covered everything that I was thinking about.
Okay.
Yeah, same with Jennifer. Nothing further to add. Thank you, though.
Thank you. Moon.
Hi, Marty. You mentioned the digital innovations, and I was just wondering, what would it take for coordination at the federal level down to the state and locals about having uniform digital travel monitoring? Because I think states and locals end up having to make up their own or develop their own systems, and because all the international airports and the way people come in, without one uniform system, it would be really difficult. And what would it take from your standpoint to have that kind of coordination at the federal level for digital traveler monitoring and post-arrival monitoring? Thanks.
So first of all, I totally agree with you. I think some of the problems that we face with federalism and with response has to do with the sort of quick homegrown solutions, which become, passionately embedded, and then we're writing interfaces rather than coming up with comprehensive solutions. So I do think that it's worth the effort to put into. I actually don't think the technology is a limitation here. We've used COVID pandemic response funds from ARP, and we've done this in other types of responses with Ebola and follow-on incubation monitoring. And I think that we've now seen a number of things, as Jason pointed out, both domestically, whether it's a Sarah Alert solution or a vSafe or other means, that we have some models of what works. I think what we need is a group that gets together with all the right equities, talks about here's the pros and cons of various technologies, here are the specifics on the needs and requirements across the user base and the equities, settle in on it, invest in it, and then build it, moving forward. Because if everyone keeps kind of holding on to what they've got and only willing to write interfaces, we're going to constantly be stuck in the Tower of Babel here. And so I think anything you all can do to look into that and stimulate and advise it. I think that the solutions probably are not merely technical. I realize there are privacy concerns and lots of other things. So I would say there needs to be a legal group involved in securing, properly securing the information and dealing with privacy issues and boundaries on those sides. But I think once the right folks with equities can be brought around the table, the right panels of experts can feed into the process, we can invest probably less resources in defining a holistic solution than constantly having translators at every level of the Tower of Babel.
Thanks so much, Marty.
Marty, I want to thank you very much. That really helps clarify and focus our work. And again, let me just thank you for that. And we know where you are. We know how to find you. We're now going to go to our next panel. So the two folks we're going to have speakers is Dr. Rima Kabaz, who's the director of the National Center for Emerging and Zoonotic Infectious Diseases, and Dr. Jay Butler, who's the deputy director for infectious diseases. So Rima and Jay, welcome, and thank you for being here this afternoon. Good to see you both.
Thank you, Georges. Yeah, thank you, and great to see you too. Okay, I was going to start, but Jay, we hadn't discussed this. Did you want to go first, or do you want me to go first?
Go ahead, Rima. It looks like you're first on the agenda, and I'll probably bring a little different perspective.
Okay, thank you. So yeah, I'm going to be brief, actually. I want to start by thanking Julie and her team for taking on the study, and all of you for for your time, for serving on this committee, and ahead of time for the recommendations that we're really looking forward to as we look to shore up our capacities and what we do in this area. So I've listened into the discussion with Marty now, and I went back and listened in a little bit on your discussion with him earlier as well. And so what I wanted to, and pretty much, I echo the charge that, the task that that Marty and the team put for you. From my perspective, I wanted to let you know that last year at the center level, we began some thinking, reflection on the pandemic and response that really our center and our staff have been heavily engaged on. And thinking, what can we do different? Where should we try to strengthen or learn from? And there were 4 functions that we decided were really unique capabilities for the center, where we needed to focus on thinking through how to be better prepared and what we could do differently or more, or et cetera. And one of those, no surprise, is really quarantine, travel, border health, and migration. So this is one area that's, as you know, and you've heard, in more granular forms is very specialized, and that the division brings in. And just to say, for every response that CDC has done in the past, decade, I've seen, the division has been one of the first groups to stand up a task force, a global migration task force, and be at the table. And a difference with all of the other groups that contribute to a response is that they're there from the beginning and throughout all. Whereas in other areas, we're able to rotate staff in and out, have some continuity, but different. In this area, it's so specialized. It's really Marty and the team are there the whole time. And the challenge has been to scale up, and you've heard about the contracts and bringing people to help, but it's been really a mainstay. And then the other thing that I've observed over time here is, and you've heard from them about, is the scope of work and expectations that have only gone up over the scope of what they do, not just in responses of the things that they take on, and the expectations. And of course, with the pandemic, we've seen that amplified. And so just this past year, along with responding to COVID, they've engaged on 2 Ebola outbreaks in DRC. They've had staff teams to address issues of migration and quarantine and border issues. They've also, the Afghan resettlement, we've stood what we call graduated response, which is an IM structure within the center to assist with that. And you've heard on the work that they've done with that. And then the southern border. So just to say, there's 4 areas from my perspective that really I think we need, that have been challenges where we have gaps. One is capacity, and you've heard about capacity, certainly capacity at the quarantine station, but also here and everywhere. And like you've heard, we've been able to scale up with some contracts. We've had supplemental funds every time. The base funding has not changed, but we've had supplemental funds that come and go. With COVID, we have significant supplemental funds, and we're starting to address some of the gaps that we've identified, but then how do you sustain that? So that's one of the capacities, and whether, the staff really are burning, just working around the clock, not just shifts, and it's the same people, and they're losing some staff who really, are passionate about what they do, but they can't sustain what they do. So thinking, how do we do this differently? We need more, but we also need to think of different capacities or some, and your questions were spot on. Are there other assets and places within CDC and outside that we can leverage? The second area is systems, and last year, remember sitting in a room and we're talking about getting passengers information, and we're still talking about how do we get it and how do we get it in time. I mean, we're making progress now that we have funds and we're trying to leverage better systems, but we have way to go, as you've heard, about having systems that are more nimble and use, all of the discussion. We need to be building a digital system for managing, travelers and following up. And there's lots of innovative ideas and things that, we can do and bring in that space. The third is the authorities, and you also touched on it. Those, quarantine authorities, how do we, 3,000 quarantine orders, mass orders we have. How do we do that? How do we manage them? And there are also other authorities that we've leveraged in COVID that we've used, and how do we manage them? And are we the appropriate group? I'm thinking the eviction orders. Are we there? We don't, in some areas, we don't have the right staff, right, to implement. And so thinking through what more authorities do we need, what different, who else maybe should be holding either the authorities or helping follow through on that. And then from authorities, I will just move on to say we've used more regulatory authorities in the maritime space, right? So that's the fourth area that I wanted to touch on, the maritime space. And I know Marty mentioned, the cruise ships and the work we're doing with them, and conveyances from no sale orders to now conditional sale orders, and then looking ahead. So how do we do that? The peacetime thing for the maritime space is a vessel sanitation program that's in another center, and it is a funded, it's user fee, and not that that's not the right model, but there are, what are the needs and how should we be positioning for longer term role in this area, whether regulatory, whether it's growing the relationship. So I think I will stop here. It's again at a high level. I don't think I'm saying anything new that you haven't heard from Marty and the team, but just to say, that really we look forward for your input and perspectives on how to move forward to how to modernize, to learn, to for the next version of global migration and quarantine. Thank you. I'll stop here and pass it on to Jay.
All right. Thanks, Rima.
Well, thank you, Rima. Thank you, Georges. Thank you, everybody, for taking time to be able to participate in this process. I see a lot of old colleagues and some that I've actually not worked with in the infectious disease realm before. So it's really an honor to be able to talk to you today. I will say in passing, it's quite a thunderstorm here. So if I'm suddenly vaporized or lose connectivity, you'll know what happened. The perspective that I want to bring is actually not so much of a CDC perspective. I know tomorrow you have a session with city, county, and state officials. You'll be hearing from Maryland and New Jersey. But I wanted to also bring the perspective from the time I've spent doing 2 stints as a state health official in Alaska, and also spending 5 years in tribal health in Alaska. But I want to start actually back when earlier in my career at CDC, when I was director of the Arctic Investigations Program. And Georges touched on this, on the issue of deputizing staff. And I think that's the experience in 2003 with the SARS outbreak is a good example of the limits on that the state at that time really did not have the capacity to be able to start meeting flights. There was a daily flight from Taipei that arrived nonstop into Anchorage. The practice at that time at all of the receiving airports from parts of Asia was to be able to greet the flights with medical staff, to be able to do a quick symptom screen. And that was a challenge for us in Alaska, where there was not a quarantine station at the time. Now, one of the advantages that we had was the Arctic Investigations Program. So there was a CDC station in Alaska with personnel from CDC that could easily be deputized, and were deputized as an extension of the Seattle quarantine station. So we were able to provide that service, but most states will not have that type of CDC personnel available. And additionally, we all have day jobs, so it's not an easy thing to do. I mean, we had to develop a rotating schedule for who would go to the airport each day to be able to greet those flights. The other thing I wanted to say about the time that I spent at the state was the value of the day-to-day operational support that we got from the quarantine station, which was particularly true once we had a quarantine station in our own backyard. And maybe I can summarize what I'm going to say in terms of, from the perspective of being outside of CDC, the two big advantages of having a quarantine station is we had that subject matter expertise just right at hand. And then we also had the staffing surge potential, whether that was to actually have the staffing through federal resources, or that would be organizing other resources. If I could touch just a minute, jumping back to 2003, that was not as easy as it sounds, because keep in mind at that time, the Department of Homeland Security was only a year and a half old. So we really were doing a lot of things on the fly at that time. And we've had many years since then for that relationship between the Department of Homeland Security, Customs and Border Patrol, and CDC Division of Global Migration and Quarantine to be able to gel a bit. But particularly in locations where there's a lot of tourist travel, a lot of international travel, in the state of Alaska with less than 1 million residents, but over 2 million visitors each year, this was vitally important. And that legal authority as it applies to the maritime system is especially important. It was not infrequent that we had measles cases or mumps. Of course, outbreaks of norovirus happen in the north, just as they do in the south. And these were issues where it was incredibly helpful to have those relationships already established with our local quarantine station. During the time that I was with the Alaska Native Tribal Health Consortium, it was also fabulous to have that relationship. And I'm not sure how many opportunities there are for Dgmq to be working directly with tribal health leaders, but that was during the time of the 2014 Ebola outbreak. There was, people noticed for the first time how many cargo ships had Liberian flags, and we were just getting inundated by calls from tribal leaders concerned about these ships that were coming into port. In southeastern Alaska, the cruise ship industry is an important part of the cash economy. And whenever there was either outbreaks of norovirus or concern about epidemic disease, such as Ebola virus, there was decisions that had to be made at the local level. There was also a lack of public health authority. I think I'll be very transparent and say sometimes the state wasn't as responsive to some of the local needs that were expressed, and being able to have the federal authority, as well as the more customary relationship between tribes and the federal government, was hugely helpful. As we think about COVID-19, kind of fast forwarding now to the past couple of years, once again, I'm going to bring an Anchorage perspective here, because that first repatriation flight first touched down on American soil in Anchorage. And that's another example of the staffing surge capacity that was made possible through the standing relationship between the state and Dgmq to be able to figure out where were the areas that that federal employees could go, where were the places state employees could go, to be able to do that screening and be able to continue that flight on its way to the repatriation site. I think we've already touched on issues around the borders. The southwest borders, of course, is a hot topic, and the unaccompanied children crisis right now, as well as the Operation Allies Welcome. We have no shortage of refugee situations, and the Dgmq mission seems very well aligned with the needs there. There are areas where I think we have to figure out what is the alignment of the mission. One is the issue of housing that we've already heard about. That is not an area where CDC has expertise currently or during this whole process of figuring out where to quarantine people during repatriation. The Department of Defense has proven to be very helpful as time has gone by. But early on, that was a little harder because we, at that time, didn't have a public health emergency declaration. Groups like FEMA that oftentimes provides temporary housing in an emergency situation, they weren't activated yet either because of the lack of a declaration or application of the Stafford Act. The legal authorities is another area where I really look forward to input from this group. Marty has, and I think Rima also have already mentioned the eviction moratorium. That made a lot of sense as a public health intervention, at least it did to me early on in the pandemic. But as time went on, more and more it was being used to address the health issue and the crisis issue of evictions, yet less and less did it really align with the legal authority of CDC. And of course, in the end, it was eventually turned over in the courts. There's no denying that eviction is not a positive public health event, but whether or not CDC's authority to have been applied for as long as it was, I think is something that's still being debated. And so the question is whether or not there needs to be authority that's applied to other parts of government that are better suited to be able to address things like an eviction moratorium. Another example might be on restriction of immigration. Title 42, I'm sure we could debate all day on, but currently it's a public health intervention that's being applied to enforce immigration policy. Finally, I just want to close by saying, this is a remarkable opportunity that we have, and I know everybody on this call recognizes that, to reinvent public health for the 21st century. What we need to address nowadays is different than what it was 30, 40, or 50 years ago. And we need to think about how to make a public health system that's more agile and can address how we live now in the 21st century. The example of contact tracing is one that is both extremely frustrating and also extremely gratifying that we've made some progress in the past 2 years. And I use that as an example because that was a major headache during the 2003 SARS epidemic. And really not much happened until COVID-19, which highlighted the challenges that we currently have in being able to track people who traveled internationally. While it's still not perfect, and I've already heard some references to that, I think it does show that things can change, and maybe now is the time to make those changes happen. So I'll stop at that point. I'll turn it back to you, Georges, and I look forward to the discussion.
Great. Questions? Stephen.
Thanks, Georges, and thanks to both Rima and Jay. You sort of both alluded to the regulatory environment. So I guess I would just sort of make a general question to both of you. From your perspective, Do you need more authorities or do you need less?
I'll be glad to start with that and then turn it over to Rima. I don't know if it's more authorities or less, but I think the answer is the right authorities with the right agencies. Right now, I think there's a little bit of a mismatch. I think I'm going to use the example of the eviction moratorium again, because that's the one I've been most directly involved in. A real upside is I think it really firmed up our relationship with the Interagency Council on Homelessness, as well as housing and urban development. But for instance, HUD has no authority to do the type of thing that CDC was doing. Whether or not that's a better place for the authority for an activity or an interdiction like an eviction moratorium, I think it's one of those areas where I'd really like to defer to some of the legal scholars as well as members of this committee to get your input.
Yeah, no, I think Jay is right. It is just the right. And so there may be more in some areas, Steve, and less in others, but also in areas where it is a public health domain and public health authorities, then how to manage, the management and implementation may not be a public health CDC. So some clarity on responsibilities. And then there's this thing that Jay alluded to, public health, authorities that we have can be used for other purposes. And I don't know how you can help us with that, with recommendations that, that those authorities be driven by public health and we don't sway. I mean, public health is inherently political, so I suppose it may not be completely possible. But
well, this is George's. One of the questions is, so when you do isolation and quarantine, we're protecting people who either have a disease or who we may think have a disease from other people. The homelessness or the moratorium for putting people out of their homes was to protect people from being exposed. So it's in some ways, right? It was kind of a reverse of what we normally do with isolation and quarantine. Can you think of any other situations where that might be the case? I mean, we closed businesses, schools, and other things in many ways under that same concept, that same philosophical concept. You didn't do it per se, but the government did it. The United States government did it broadly. So I guess the question is there some protective guidance that has to have under the umbrella of health to make that more more focused? Because we kind of closed all schools, but maybe that wasn't the right task. We kind of closed all businesses, but that was not necessarily, in some cases, the right thing to do. And I'm not quite sure that we looked at the holistic health impact of that. We looked at the infectious disease impact of it, but not necessarily what was the mental health aspect of it. What were some of the other downsides for closing things or for keeping people from being put out of their homes? I mean, we just didn't look at that in a holistic way. I know I threw a whole lot out there, but any thoughts?
Yeah, maybe I'll just start it in terms of, I think your point is very well taken. And that may be part of what led to some of the polarization that occurred, particularly as we get into May and June of 2020, as the number of cases declined fairly dramatically. And more I heard people on various webinars and partner calls I was on saying that the problem wasn't the pandemic, it was the pandemic response. And there is, I think, I don't agree with that statement at face value, but I think there is a grain of truth to it in that the evaluating the gains and the losses of social distancing, particularly when we start talking about shutting down businesses, meaning the economy, or school closures, which makes it very hard for people to be in the workplace, creates those issues that are very challenging economically, and which then begins to impact health, and also drives some of the inequity that we saw, that people with a variety of privileges were much more able to avoid the impact of those distancing measures, and also to be able to participate in them. Marty, I see your
yeah,
hand.
Marty has his hand up.
I just wanted to comment about something that was a little different about eviction than school closure or business closures, which in fact were largely relegated to state and local legal authorities rather than federal legal authorities, and that CDC's recommendations around staying at home if you're sick, or in some cases early on as well, in quarantine if you were in this exposed arena, the ability to actually follow public health guidance with regard to isolation and quarantine that was decentralized into a home was directly in contradiction to eviction, in which people would be forcibly homeless, and the inequity issues. So it is a little different, but I understand your point, George, is that what we were doing is trying to enable a place to be protected, but also a place to safely isolate and quarantine, directly. So it wasn't just about sheltering from a place that posed a potential threat. It was about safely sheltering in a place so that you wouldn't pose a risk to others. I think that's perhaps an important distinction. That being said, all of Jay's comments, I think, were spot on about whether that type of authority to deal with eviction and homelessness in the setting of an infectious disease threat are better situated under another agency's regulations and so on.
And if I could just add to what Marty just said, it was more than an issue of people being turned out on the streets when evictions occur. The data indicate that the majority of people who are evicted end up doubling up. And early on, even before we recognized the magnitude of transmission from people without symptoms, it was very clear that the highest risk of exposure and transmission domestically was within the household. So that issue of household crowding is one that we recognized was going to be very critical to control early on. So that's another reinforcing factor that I think drove our decision making to get into the business of the eviction moratorium.
Yeah. Well, the other thing, of course, normally eviction moratoriums occur at the local level, but they usually occur for weather, right? Heat, cold, etc.
They're usually fairly short-lived too.
Yeah, very much so. Lonnie.
Great, thanks. It was a very good conversation and very helpful today. And so listening to Marty today and previously, and then also to Rima and Jay, I mean, you're really kind of challenging us to rethink and reimagine the possibilities of Dgmq. So my question would be, if we go down that line and our recommendations, which we don't know what they are today, but are kind of reimagining and rethinking, maybe reoperationalizing, how would those be accepted by the organization, by Dgmq? Is this a time that kind of a change strategy would be acceptable? And how would you answer that?
Yeah, let me start and Marty can. Alani, yes, this is a time we are asking ourselves what changes we need to make to be, to be fit for purpose going forward, given pandemic, given COVID, and given what we think will continue and continue to accelerate. So it is the right time to get to recommendations as we think through what changes we need to make. Marty?
Yeah, I just want to, sort of foot stomp on that. Over the 25 years, for me at Dgmq coming into the program in 96, I see us having been in 3 phases of reinvention. 96, we were really just coming out of a mothballed state of 30 years, you know, with Jim Hughes, you know, and others wisely saying, look, the then IOM report of 92 on EIDs means we need to rethink our space. That first phase of reinvention, you all participated in, it was critically important. It took us through SARS and a little after. I think we were better positioned after the SARS, the motivation of the SARS crisis, but not quite there. And I would say that was phase 2, like the early 2000s till now. We've stretched this, but we've seen the last 10 years an acceleration both of the types of threats, the duration, the frequency, and the intersection across other migration emergencies. And I think very much so, I've referred to with my team as this is the opportunity for post-COVID or during COVID reinvention of phase 3, you know, Dgmq 3.0. And I am grateful that Rima and others have supported this deep dive look, and we're really looking forward to it. So I'm as receptive and enthusiastic actually on what you guys have to offer.
Thank you, Larry, and then Stephen.
Yeah, well, first of all, Jay, I absolutely loved your talk. I thought it was fantastic. And one of the things you said, I thought Marty just reiterated beautifully, is, you know, I do think we should think about this as the idea of kind of reinventing US public health protection. I know we can't go too broadly, but as broadly as we can go and kind of rethinking it, I think is really crucially important. Then, you know, just getting on to the question that, you know, several of you, Rima, Georges, and others have been asking about, we're going to need to be very careful as a committee because we're going to need to first separate federal from state and local and public health from other agencies. So for example, most of the school closures went through education authorities and they were local or state, and, you know, federal government had, you know, could provide guidance, but they could not have any power in that regard. So we just need to be careful at that coordination between federal, state, and local. On the federal level, this is really also very tricky, and we're going to have to be careful because, you know, first of all, we need to protect the reputation and public trust in CDC. That's job one. And so we want to make sure that we give CDC all the authority it wants, but we don't overreach. And I think, you know, with the eviction moratorium, I was actually quite supportive of CDC for the reasons Rima and Jay and others have said at the beginning, and actually even at the end, because I loved the fact that you started off your interim rule as a moratorium by giving the public health justification. I thought you did it really well in terms of how it would lead to spread. But I predicted right on day one that you would be in a whole heap of trouble in the courts. And you were. And then even when the Supreme Court literally told you that they were going to slap you down, you still did it again. I know that wasn't you. I'm sure it was at the president's office. I know that. But so we do need to protect you. And then but we also need to think about when, you know, public health intersects with, you know, a federal housing or other kind of agencies, how we deal with this legislatively, policy-wise, public health-wise, because there's more and more going to be intersections where public health is permeating beyond its traditional powers. So how do we protect CDC's trust, confidence, not overreach, while still trying to enable an effective all of government response? And I think the all of government response is the key here.
Stephen.
Yeah, thanks. You know, Rima, you said something fairly interesting, which I hadn't really thought of when you were talking about the maritime unit and the fact that the vessel sanitation program actually functions by user fees. I worked at FDA for a number of years. 60% of the agency budget is funded by user fees. I seem to remember at some point in the past, Marty, when I was still at CDC, that there had been some discussions about adding some user fees into the immigrant screening process to be able to support some of the health-related activities. I don't know if that ever happened. But what you've brought up, and it's been a perennial problem, that the funding sort of, shows up and then dries up and then shows up and then dries up. Have any of you given thoughts to other opportunities for user fees to be able to provide a more stable source of funding for the division's activities?
Yeah, Steve, I'll sort of tackle that. I think that it's come up a couple of times since. Once we went down pretty far into that process, into the sort of executive budget proposal phase in prior administrations, it's a while back. We've revisited the topic periodically, and I think that for a variety of reasons that hasn't moved forward. There's the other side of how the user fees are framed. So in the vessel sanitation program, which, as you said, has a lot of funding related to user fees, most of it does not go into it's separated from the regulatory authority at Dgmq. So the program is separated. A lot of that has to do with supporting new construction, safer, healthier construction as new vessels are being built out. But very little of that has gone directly into any regulatory oversight. That is up until now in this pandemic. So in the 2 years where the regulatory framework with the industry, has clearly had a set of interests that need to be, deconflicted in some settings. And in that setting, the vessel sanitation program staff have come over to Dgmq for the last 2 years, essentially, and worked under our regulatory structure and are providing some critical value there. So I do think that as we think about user fees, and you'll probably be another good expert to tell us how you create the appropriate buffers between a regulating entity and the use of user fees to mutually move a base forward without getting into conflict of interest.
No, I agree with that, but I will say that the thought of a small fee on airline tickets to support all the quarantine stations, since they're all located at airports, wouldn't be that far-fetched.
Yeah, just to say.
I'm sorry, just one comment about that before I turn over. So that's the argument we made, but what we were told is user fees are quid pro quo for a particular service, like user fees to enter a national park cover. You pay that fee, you can enter the park. It's not actually meant to define the entire basis for supporting the national park service. And so when we proposed that, a small amount of money on a ticket, an airline ticket to cover the program activities, what was told back to us is, what is that person getting very specifically quid pro quo for paying that fee on that ticket on that day? And that's where it kind of got stopped at the last conversation we had on the topic.
Interesting. Lonnie.
I just want to pick up on what Stephen had to say, because when I was in agriculture, we were told all the time that user fees couldn't be done. And then all of a sudden, most of agriculture quarantine work is now user fee funded. So, there's an agency, similar kinds of activities that are highly related on user fees, and it's been accepted by industry now. So just because you've gotten to know in the past doesn't mean that, what's happening today wouldn't put that under different light.
Yeah, it's the service is in the eye of the beholder and the wisdom of Congress, right? One of the things I always, when we were talking about the eviction moratorium and the agency that's most appropriate, certainly one has to think about the legal authority But you also have to think about the expertise of the agency to understand the legal authority. I'm not quite sure what expertise housing and urban development has. I know they're always challenged when they try to talk about even the anti-tobacco issues, when they got into the big debate about tobacco use and whether or not you put someone out of their apartment because they're using either drugs or tobacco. When the department was moving, housing was moving to an anti-tobacco mindset, it was a big issue for them to think about the public health implications of that and then crosswalk that with the authorities and the actual implementation of who got put out of their apartment, because once they got put out, they ended up being homeless. But the health implications, I mean, there was a lot of debate about how they had to engage people to get that health advice. But just kind of from a broader conceptual concept, most of that health authority, most of that health knowledge and expertise is at CDC. It's not really at those other agencies. Would everyone agree on that? Yeah. And even Homeland Security, although it has a medical director and a health entity, it struggled a lot to in some of its health authority because of infrastructure, very much limited infrastructure. Ed, any thoughts about that? Even DHS?
Yeah, I can start with that in terms of working with HUD. Your point is very well taken. HUD is not a health agency. CDC is. Housing is a social determinant of health. So there is a lot of activities in that lane that's very appropriate for us. In terms of where the legal authority should lie, then I think is really the question for debate. And it does highlight the importance of the interagency coordination and cooperation that, at least in the case of working with HUD, is moved forward very dramatically over the past year and a half. I think we're also making a great deal of advancement working with Department of Transportation also, which of course begins to apply to some of the discussion here, but is much bigger than just international travel when we start looking at mobility as a social determinant of health. So I guess I just really want to start the conversation by affirming what you're saying in terms of where the health expertise lies, but highlighting again that conundrum of where the legal authority should lie for some of the activities that may not have the same direct health impact as, say, at least as it's currently worded in our quarantine authority.
Yeah, just to add to Jay's comment, that I would say, look, I spend most of my time now in interagency discussions across all of the USG and, policy formulating committees, deputies committees, even the level of assisting or plus ones in principal conversations, because of this intersectionality between the social determinants of health and how they apply across all the USG departments and agencies. So that is the probably the biggest time part of my job, is not just being able to articulate the health rationale, but also to help broadly people understand our authorities and, quite honestly, our dependency on the interagency for implementation. Most of our orders and regulations have been accompanied by directives that come out of an implementing department and agency, whether it's Department of Transportation on surface transport and mask use, or Department of Homeland Security and TSA on in-flight issues and mass testing requirements, intersections from those departments to their industry partners. There is no doubt that large-scale events like this are whole of government and whole of society engagements. I do think that a lot of time is spent actually syncing up and getting clarity and making sure we move as a united federal entity, and also in our relationships with state and local partners, but also with other places where there's equities in industry. So there's no doubt that it's not a one place thing, just as Jay pointed out. It's a huge part of the integration, but how we tease out which statutes, regulations, authorities are used, where they're consistent, where one can be nested and followed as a logical extension of the other, or what adaptations have to be made. For example, Homeland Security Secretary had to declare that a COVID public health emergency could constitute a national security emergency in order for them to issue security directives that targeted the airlines to do certain things like, checking test results before passengers boarded, et cetera. So it is a very complex space, and I look forward to the special focus that Abby is going to offer you all on some of those intersectionalities, because I think they're really critical.
Right. Michelle.
So building on that, Marty, I know Abby and Larry are going to be working on some of the regulatory issues, but between Rima, Jay, and yourself, is there some sort of vision of how to harmonize these sectors, and particularly harmonize around public messaging?
So I would say that every time we roll out these changes or new authorities, we do have that process by which we engage those with equities, not that they get to shape any of the regulations, but the considerations on operations and implementation. And then all our communication folks are synced up on making sure the messages are coordinated. There are times where some of the agendas and some of the places of the authorities may need to be deconflicted. And I think Rima alluded to sometimes where we have to make sure that because CDC has the authority, it doesn't get co-opted by a particular need of a different department and agency under the guise of public health in other settings. So we all have to be, mindful of our own boundaries, as well as the need to be very, very well integrated. I do think that by and large, given the amount of regulation that has been unfolded at the federal level during the last 2 years, the messaging and the coordination and the integration of operations and rollout and across the sectors and with partners has been really quite impressive. I mean, having been involved in interagency conversations for a long time in my career, the last 2 years are some of the best integration that I've seen. That's not to say that there aren't, tension.
I'm not talking at the federal level. I mean, just in California, my county has different recommendations than the county adjacent to me.
Yeah, I think that's a whole different, I think that issue of federalism that Larry has brought up in his insightful remarks, that boundary in the handoff and in the jurisdictional space and where federal public health authorities interplay and how they get coordinated with states and even beyond, with counties. And as I think I said in my opening comments when the committee, first started, this issue of internecine rivalries across the spectrum of public health is a bigger challenge than the pathogens don't face the same. So we end up being very vulnerable and at risk to our internecine rivalries where the pathogens really don't care. How that gets navigated is one that will require great art, as Larry has said, and great caution.
Can I add? It's complex, right? And it needs a lot and constant work and a lot of time. It takes a lot of time, whether it's at the federal, that coordination that Marty alluded to, or federal, state, local. So and maybe that's what it is, but I wonder the progress made in response, whether there's some recommendations to kind of institutionalized that need, you know, I don't know if roles coming together, some more seamless interactions that get us to where we need to be. That's what I meant by clarifying maybe roles and whether it's a authority, but then, you know, who manages and implement. And I see us spending a lot of time again and again trying to address that. And maybe we've made progress because of the pandemic, but I don't know. Those don't want to lose lessons learned.
Yeah, but Michelle, I think you make it such a good point, and it's an issue, not to get us off topic, but the whole concept. We've so many times just in the past hour and a half, we've brought up the federalism that's involved, and sometimes people say the patchwork quilt that makes up our public health system. But if it's a patchwork quilt, yeah, we have pieces of cotton and wool, but we've also got pieces of old paper and wet lasagna that are sewn into it. And it just doesn't create a functional way to stay warm.
Excellent, excellent. Are there any other questions before we let these kind scholars leave? Stephen.
Yeah, I have one more, which is, you know, again, looking back at my FDA experience as a regulatory agency, we often provided funding to the states to be able to do a number of the things that we couldn't do all of them ourselves, including inspectional activities. Is there, and Jay, I would sort of, you know, look at you, are there some circumstances in which, you know, if you're not going to have unlimited ability to bring on more and more people to staff some of these quarantine stations the way that they ought to be staffed, is there some way that under the quarantine, federal quarantine authorities, that could be delegated to the states with funds to be able to have some of them done by the state rather than by CDC and the quarantine division itself?
Yeah, I think it's quite feasible. I think the two areas of the two challenges that will have to be overcome is, first of all, the perception that it's any kind of federal overreach, that it could be perceived as resources to be able to develop the local infrastructure. And the second challenge, I think, would be a part of that is to reassure states that it's a sustainable resource. I know there's a number of states that have gone so far as to even introduce legislation to limit the federal funding to public health to fund sources that last beyond a period of, say, 3 to 5 years, because there's a concern that there would be this new federal program. It would be funded for the state to implement, but then the funding would go away after a year or two. And as you're well aware, after a year or two, sometimes these programs are just getting up and running. It's very hard to show the success of the program, and there may be resistance at the level of the Finance or Appropriation Committee in the state legislature to support receiving those federal funds if there's concerns that the burden is going to fall on the state in the near term.
Yeah, but as you pointed out a little bit earlier, that you were the ones that were meeting those planes in Anchorage, and that all of those people that were doing those types of things had day jobs. Yeah. And so this could be an opportunity to have, you know, people this is their day job do some of this.
Yeah, but that was one night. So I think the question at hand is this going to be an ongoing program? So, but your point is very well taken. And I think the bottom line answer for me is, yeah, it is feasible. We have to look at what some of the challenges that we would have to address to do that. But I think the concept is very good. Good one to bring up with the state and local leaders tomorrow as well.
Mm-hmm. All right. Any final questions? If not, I want to thank you all for being here. This is the end of our open session. We're going to be going into a closed session. And I think we're going to come back at about 2:40. So thank you, everyone. Appreciate it.
Thank you all. Appreciate it.
All right, we're currently off live.
All right. Now we continue the recording, correct?
Emily.
Emily?
Yes, I was gonna stop the recording actually.
Okay.
Yeah.
And
we don't have to edit.